I'm Howard Chansky. I'm the chair of the Department of Orthopedics and Sports Medicine. Welcome to our May Grand Rounds. And this morning we have Dr. Jason Shu, the chief of our shoulder and elbow service, and Dr. Jonathan Yamaguchi, one of our R4s, who I believe is going into shoulder and elbow surgery. And they're going to be talking about advances over the last 10 years in the care of patients with prosthetic joint shoulder infections.
Thank you for that introduction. Again, I'm John Yamaguchi. I'm one of the fourth-year residents, and yes, I am going into shoulder. I'm happy to kick off Asian American Pacific Islander Heritage Month with Dr. Jason Shu, and today we'll be talking about shoulder prosthetic joint infection, what we have learned in the past decade. These are our disclosures. So again, I'll be providing the overview of shoulder PJI with regards to the epidemiology, what makes shoulder PJI unique, namely celiac knees, and the diagnosis of shoulder PJI. So the number of shoulder arthroplasties is significantly increasing. The study by Wagner et al. Reviewed the national inpatient sample from 2011 to 2017, had a projected increase in shoulder arthroplasties or primary shoulder arthroplasties to 175 to 350,000 cases by 2025, which mostly outpaced hip and knee arthroplasty. This was largely driven by the increase in reverse total shoulder arthroplasty, which was projected to increase 350% from 2017 to 2025. With the increase in primary shoulder arthroplasty, there's also an increase in revision shoulder arthroplasty, which is a major source of morbidity and mortality. This study from 2021 from the same group noted an increase in incidence of revision from 2011 to 2017 with a similar increase in cost. And part of those revisions are related to the periprosthetic joint infection cases. So this study from Schick et al. Again evaluated the national inpatient sample database and found that PJI was found to be about 1% of all shoulder arthroplasties, and from 2018 to 2030 had an estimated 176% increase in periprosthetic infection cases. And this study from Dr. Baillot and Dr. Walsh's groups in France demonstrated that the leading cause of multiple reintervention were infection instabilities. So from their 10-year case review, they looked at 540 failed arthroplasty patients and determined that for multiple interventions, 21% of the patients required multiple surgeries, mainly for infection and instability, which is about 25%. So what makes shoulder PJI unique? One of the main reasons is due to the skin microbiome. The skin microenvironments are broadly into three categories based on density of hair follicles and sweat glands. First one is sebaceous or oily, which is predominantly dominated by Cutibacterium. And then moist areas, which predominantly hosts Staphylococcus, and dry skin, which has the greatest biodiversity with a mixed population of Cutibacterium, Staphylococcus, and other skin flora. So Cutibacterium acnes is a gram-positive rod. It's a facultative anaerobe, but is also aerotolerant. It is slow growing, which requires longer incubation periods. It can also produce biofilms on prostheses. So Cutibacterium is found on the skin and demonstrated as the green rods on this diagram, but is also found in the pilosebaceous units in the dermis, which are anaerobic and lipid-rich. In adolescents, Cutibacterium acnes, as the name suggests, plays an important role in the pathophysiology of acne vulgaris, which most of us are all too familiar with. As a normal part of our skin flora, Cutibacterium has three main roles to aid in skin homeostasis. It uses the triacylglycerols in sebum for energy and produces short-chain fatty acids, one of which is propionic acid, which is its former name. And it was reclassified in 2016 due to biochemical and genomic studies, with the cutaneous species distinguishable from other species from the Propionibacterium group. And propionic acid not only modulates the pH, but is also thought to have antimicrobial properties, which is an important role for its next role as a competitive colonizer of hair follicles. Not only using propionic acid, as well as secreting antimicrobial peptides and inhibiting both Staph aureus and Staph epidermidis. Thirdly, its main role is to provide the skin with antioxidants to protect it from damage. Now, understanding about normal celiac knees, this provides a basis on how it can inoculate the surgical wound. After our standard surgical prep, although celiac knees are removed from the skin, it is not removed from the dermal tissue and can be released during incision. where it still resides in the sebaceous pilosebaceous units. In both of these studies with Dr. Matson and Dr. Pottinger, there was a demonstration that Cutibacterium, shown in green, was the most common in the unprepared skin. But even after the skin preparation and incision, there was still a fair number of positive dermal samples. In fact, Cutibacterium can inoculate the entire surgical field, where the study showed that the predominant organism was C. acnes. It was found on the subdermal layer, tip of the glove, both inside and outside scalpels, and forceps. And a more recent study by Schroff et al. In JSCS in 2023, they were evaluating the utility of changing scalpel blades, and actually showed that the outside scalpels showed a 12% positivity rate with C. acnes cultures. So with the inoculation of the surgical wound, anaerobic and biofilm producing properties, it's not a surprise that the most common organism is C. acnes. But what are the prognostic factors for C. acnes culture positivity? Dr. Pottinger and Dr. Matson colleagues reviewed 193 revision arthroplasties for stiffness, pain, or loosening, and found that 56% positive, 56 of these cases had positive cultures, 70% of which had positive cultures with C. acnes. They found that the risk factors separated both in pre-op imaging and intra-op areas were predominantly in preoperatively was male sex. On imaging, humeral loosening and humeral osteolysis on X-ray. And intraoperatively, glenoid wear, osteolysis, membrane, cloudy fluid, and a number of cultures were significantly associated with the increased risk for C. acnes. On their multivariate models, they separated between stage 1 preoperative characteristics and stages 2 and 3 with radiographic and operative characteristics, and found that male and humeral osteolysis on X-ray were the most important factors. Clinically, notice that those factors did not include classic findings of PJI that we were taught to look out for, such as pain, erythema, sinus tract, elevated inflammatory markers, which we can describe as the more obvious virulent side of the spectrum, versus low virulence, which often describes C. acnes with nonspecific findings of pain, stiffness, and normal inflammatory markers. But the spectrum of virulence is a spectrum of clinical presentation. Although the diagnosis of PJI is often reliant on culture data, there can be prolonged incubation periods and difficulty evaluating the culture data for low virulence organisms. They're also relatively nonspecific, so determining preoperative risk factors can be determining how you manage these. So again, the virulent side, as with the classic findings with sinus tract, erythema, elevated labs, radiographic loosening. Low virulence could show pain, possible radiographic loosening, and intraoperatively, intraarticular pus, membrane loose components, and possible loose components on the low virulent side. We found from multiple studies that the risk factors preoperatively are being male, young, less than 50 years old, testosterone use, history of infection, and multiple cortisone steroid injections. Given this large spectrum, how do we define shoulder PJI? Dr. Hsu and Dr. Matson did a systematic review in 2017 of 20 studies that demonstrated there really was no consensus on definition of shoulder PJI. 27% of these studies did not have an explicit definition of infection. 14% used classifications for hip and knee infections, the MSIS criteria, and 55% of these papers just used their own author-defined criteria. So some of these papers, as mentioned before, use the MSIS criteria, which is commonly used for hip and knee. But as we reviewed the criteria, the major criteria applicable and often found in obvious or virulent infections, but the minor criteria don't really translate well to the shoulder, as we see the CRP, ESR, white blood cell count, and even synovial fluid can be often be negative or hard to interpret. So applying the MSIS criteria to low virulent side of the spectrum, again, we see nonspecific signs and symptoms on presentation and imaging. Normal serologic and synovial fluid labs, and synovial fluid can often be difficult to obtain, and often normal pathology. So all should be included in the thought process for management, but even with negative tests, cannot reliably rule out infection. And there's a prolonged incubation period that requires 14 to 21 days compared to our normal 5 days of incubation for virulent organisms. So oftentimes we don't know if it's infected or not, given that it's determined by culture. So these factors make it challenging to manage intraoperatively, since you will not know about the culture results for weeks. So in 2018, the International Consensus Meeting defined shoulder PJI into 4 main groups. The first group is similar to MSIS criteria and is categorized as definite, with the presence of sinus tract from skin to prosthesis, gross intra-articular pus, and 2 positive virulent organisms. The other 3 groups include probable, possible, and likely based on minor criteria, with the cutoff being around 6. Of note, the presence of multiple positive low virulence cultures without a host response cannot get you into the probable category. This helps to address the false positivity rate. This study from the ASCS Shoulder PJI multi-center group had 5 institutions perform negative control studies either with the air or sterile gauze, and found a range of false positive rates of 0 to 17%, with the cumulative rate on average was 8%, with C. acnes being the predominant organism of 80% of cultured organisms. This study, also from the same group, although less sample, was more controlled. They sent 2 negative controls to each of 11 sites and found a 14 false positivity rate, and that's with those lower strength to positivity and longer time to positivity compared to the other dilutions. So this can make it difficult to understand the clinical significance of positive cultures with low virulence bacteria with a failed shoulder arthroplasty. So now I'd like to transition to Dr. Shu, who will talk about interpreting culture results and clinical management of potential shoulder PJI. Thank you.
All right, thanks, John. So John just gave us a great background on the unique considerations we have in shoulder when it comes to PJI. So these are my disclosures. I'll start with a representative case to first show you the difficulties we have in diagnosing shoulder PJI and interpreting the culture results. So this is a 59-year-old male, had a total shoulder done 4 years ago, presents with pain after starting at 2 years after his initial procedure. Didn't have any pus or sinus tract, normal ESR-CRP. And on his films here, you can see that he has glenoid component loosening and humeral osteolysis. And the decision was made to undergo revision to a reverse total shoulder. And because of the loosening of the glenoid component osteolysis, cultures were taken, and they came back a week or so later as 2 out of 5 positive for Cutibacterium. So the major question here is how you interpret these culture results, and is this really a prosthetic joint infection? Some would say that there's bacteria there, so it's an infection. Others would say Cutibacterium is commonly a contaminant, just a commensal bacteria, so it's not an infection. And others would say it depends whether you think bacteria was a cause for the clinical symptoms like the component loosening. So in this talk, I'll go over what we've learned in the past decade, which is going to really re-emphasize a lot of the points that John made, but also talk about what we need to learn more about. A lot of it, again, has to do with the relevance of the skin microbiome, how we can prevent inoculation, and can we prevent inoculation. I'll also talk about clinical relevance of bacterial presence and what kind of preoperative testing can be done for diagnosis of PJI, and then talk lastly about the optimal surgical and antibiotic treatment. And so the vast majority of the literature on Cutibacterium and shoulder PJI has been in the past 10 years, with over 90% of the articles in the past 10 years. But it is notable, back in 2007, Dr. Matson published a study looking at 300 or so failed arthroplasties. And in the results, he noted that an interesting finding was the number of shoulders that had evidence of infection. And he also found that a large majority of those that had the patients that had positive cultures were male. And so within a couple of years, he formed this multidisciplinary research team, microbiologists, infectious disease doctors, laboratory medicine colleagues to investigate this further. And more recently, we've been doing genetic analyses of the bacterial isolates. And then also in the past few years, we've been leading the multi-center effort to tackle a lot of these difficult questions that we have on this topic. And so most of my talk will discuss some of the studies that have come out of these collaborations. So again, John really talked a lot about this landmark paper by Dr. Pondra and Dr. Matson. I think this is probably the most cited paper in the field of shoulder PJI. Again, looking at a couple hundred revisions in patients without obvious signs of infection. Over half of them were culture positive, and the vast majority were with Cutibacterium. And as was noticed in previous studies, there was a very strong relationship between male sex and positive cultures. And so a subsequent study by Dr. Matson and Dr. Baumgartner out of microbiology demonstrated that if you look at the deep periprosthetic tissue cultures, and then you take cultures from the dermis or skin, the culture positivity rate of females is essentially 0, while almost all positive cultures are in males. So naturally, when you think about male sex, you think about testosterone. And so Corey Schiffman, back when he was a resident, designed this study and actually wrote this ORIEF grant completely on his own, looking at the relationship between serum testosterone levels and skin Cutibacterium levels. And in the multivariable analysis in this study, he showed that the major driver of Cutibacterium levels in the skin was testosterone. And this makes sense physiologically, because testosterone increases the sebum production in the sebaceous glands. And so this goes, again, back to the dermal structures of the sebaceous gland. Cutibacterium is a facultative anaerobe, so it can live on the skin surface, but also in anaerobic areas under the skin, and it feeds off the fatty acids in the sebaceous glands. And so unlike other bacteria that sit on the skin surface like staph, Cutibacterium can really just hide out in the glands, and it's protected from our usual skin surface preps. And to reemphasize this point, sebaceous glands are really found around the face, neck, back, and shoulder. Whereas if you look at areas like the hip and the knee, you're looking at either dry or moist areas of the skin, which have more virulent bacteria like staph. So this has important implications on the effectiveness of our skin preparations around the shoulder. So I think we all use ChloraPrep to some extent to try and sterilize the surgical field, but we've done multiple studies showing how our standard ChloraPrep preparation and other adjuncts are pretty ineffective. So this was a study we did as a part of a department seed grant. We took skin swabs of 10 shoulders and looked at the bacterial load on the skin. And then when we applied ChloraPrep and took cultures again at 3 minutes, as expected, the bacterial load was pretty minimal. But then we cultured the skin at set intervals over the next 4 hours and found that by even just an hour, there was a substantial amount of Cutibacterium back on the skin surface. So what's likely happening here is that the ChloraPrep is eliminating the skin surface flora, but it's unable to penetrate deeper than that. And so at pre-prep, you can see that there's bacteria on the skin. After 3 minutes after the prep, you've eliminated everything on the skin, but at 60 minutes, everything in the sebaceous glands likely is repopulating back onto the skin. So you see that ChloraPrep doesn't eliminate the Cutibacterium in the sebaceous glands. We use this same model to test the efficacy of adjuncts like hydrogen peroxide to see if that improved the reduction or elimination, and did a randomized controlled trial that Billy helped us out with, and found that hydrogen peroxide, we used the same model. We treated some patients with chlorhexidine only, and then some patients with chlorhexidine and both hydrogen peroxide. And again, we found that hydrogen peroxide really didn't provide any additional benefit to reducing or eliminating Cutibacterium from the dermal structures. And then benzoyl peroxide is another adjunct that is considered prior to shoulder surgery. And we did a randomized controlled study looking at home use of chlorhexidine wash to benzoyl peroxide soap. And we found that essentially there was no utility in using either one as a home prep. And neither of them really decreased the skin bacterial load prior to shoulder surgery. So there are some studies in the literature that show that there is efficacy of benzoyl peroxide, and it may be that, in our randomized controlled trial, we were using benzoyl peroxide soap. It could be that this gel formulation, rather than the soap that we use, the gel formulation might be more effective in penetrating the deeper sebaceous glands underneath the skin surface. And so the data out there suggests that it can reduce skin loads by about 50%, but it really still doesn't eliminate Cutibacterium. So the bottom line is we haven't found a way to eliminate Cutibacterium from the skin. And when we make the skin incision, we're inoculating the deep tissue and the implants with bacteria. John showed this study where the authors cultured the skin, scalpel, gloves, and forceps. And pretty much once you make skin incision, the bacteria can get everywhere. And so presumably it can get onto the implant. So our understanding and belief has always been that the skin has been the source of bacteria that causes pathologic changes around the shoulder and can get on shoulder implants. But there's some contrary thoughts that Cutibacterium may just be native to the shoulder joint. So there have been multiple studies looking at culturing native shoulder joints at the time of primary arthroplasty and has seen positive cultures. And then there's this study that identified C. acnes in macrophages and stromal cells, and suggested that potentially C. acnes is just living dormant in the joint itself. And then there's also a concern that the positive cultures that we obtain at revision surgery are of an exogenous source rather than the intended tissue from the shoulder. And because Cutibacterium is really all over the skin of, the surgeons, the staff, there's always a possibility that the surgical team could contaminate the surgical field, or anyone handling the culture sample. So, people in the lab, when they're handling the sample and putting it onto the agar plates, maybe there could be contamination there. And so to answer some of these questions, we collaborated with our lab medicine colleagues and did whole genome sequencing of over 300 isolates from 88 patients. And these samples included skin and deep samples, and also samples from primary and revision arthroplasty. And by doing whole genome sequencing, we can construct phylogenetic trees and determine which isolates are genetically similar to each other. And so we looked at a number of different factors, like the source of the sample, the type of the surgery, sex of the patient, eventual culture result, and our goal was to see which strains were closely related to each other using this genetic information. And so we wanted to answer a couple questions. The first one was whether strains from the skin were genetically similar to the strains from periprosthetic tissue at revision surgery. And the data did suggest that skin samples from the tissue were genetically similar to the strains found on the patient's own skin. And it suggested that the skin really does serve as the primary reservoir for inoculation of the deep tissue at the time of arthroplasty. Another question that we wanted to answer was whether some of the what we're culturing in the deep tissues could be from exogenous sources or common source contamination, meaning that if we found strains of isolates that were genetically very similar, but we found them in different patients having different surgical dates, that might suggest contamination. And we did find that in 5% of isolates that was the case, where we found genetically similar strains in unrelated patients. And if we looked a little closer at this strain sharing among unrelated patients, we found 3 clusters. Over a period of months, we found that there were anywhere between 2 to 4 patients that were treated either by the same surgeon or different surgeons that had genetically similar strains of Cutibacterium. So the bottom line here is that in a small percentage of the isolates and the patients, the positive cultures we were getting were not from the patient, but rather likely from a false positive, or what many would consider a contaminant. Whether that's from the surgical team or the microbiology staff or from the general environment, we don't know. But as John mentioned, when you look at negative control studies, there are a fair number of studies that have reported false positive rates ranging anywhere from 0 to 17% when you're culturing negative controls like an air swab or a piece of gauze. And so this is a concern. It makes it hard for us to consider how to interpret the results. And so the source is likely important in relation to whether there's clinically relevant virulence factors. We did the study where we took periprosthetic tissue and normal skin control samples and grew them in each of these strains in 96 well plates. And then we tested to see which strains were able to better form biofilm on the plates. And we also tested hemolysis, which is a characteristic that you can test on the blood agar plates. And we found that the tissue taken from periprosthetic tissue from revision had significantly higher biofilm forming capacity and hemolysis formation than skin commensals. And so what this suggests is that a true positive, or a tissue sample that is coming from the deep tissue is more likely to have virulence characteristics than a skin commensal. So determining whether a sample was really from the deep tissues or a true positive versus an exogenous source, which would be a false positive, is important. And so John mentioned the study. To study this more, we did a multi-center study where we took a clinical isolate from a patient with a probable shoulder PJI. We took serial dilutions of the specimen, replicated it, and then sent these dilutions along with 2 negative controls to 11 different institutions. All the institutions were blinded to the specimen type and whether it was a negative control or what dilution the positive control was at. And what we found, that there was a 14% culture positivity rate in the negative controls. But an important finding here is that semi-quantitative culturing could have the ability to weed out these false positives. So if you look at semi-quantitative culturing, it refers to the fact that when you send a sample to the microlab, they grow it on agar plates in these different quadrants with different dilutions. And then most institutions report whether there's no growth or a little bit of growth, and then different levels of positivity. And what we found was that after the very low level of positivity, if once you get above that, there were no false positive in the levels above it. So if you have a higher strength of positivity, your chance of having a false positive was essentially zero. So furthermore, if you look at time to positivity, and look at this graph here, on this graph, the lower bacterial density is on the x-axis. As you get lower bacterial density, the strength of positivity and the time to positivity go up. And if you look at the negative controls, their time to positivity was pretty high and their strength of positivity was low. So you can use this information, and clinically, when you're interpreting positive cultures, you can consider assessing these. So instead of just saying 2 specimens were culture positive, you can that's explaining the rate of positivity. You can say strength of positivity, where it was very light growth or moderate growth. You can explain the time to positivity, whether it grew in 10 days or 3 days. And so these are very different. When you have 2 different specimens, 2 positive specimens, you can say 2 of 5 specimens had very light growth starting at 14 days, which is much different than 2 of 5 specimens had moderate growth starting at 5 days, which is probably a little bit more concerning for virulent bacteria. So if you go back to our case here, we had 2 of 5 positive Cutibacterium specimens. And again, you can use these different characteristics of time to positivity and strength of positivity to help you determine whether or not you feel like these are clinically relevant. But one other challenge we have in the shoulder is that the culture results aren't known until the surgery is complete, and these oftentimes don't grow until 3 to 14 days after surgery. And so oftentimes we're looking for preoperative signs or symptoms or tests that have diagnostic value. And so if you look at serum ESR and CRP in the literature, it really has low sensitivity. And in our multi-center group here, Andrew Collins is one of our interns, has really been helping us a lot with this. But if you look at non-definite infection and its ability to predict ESR and CRP to predict positive cultures, it really has no diagnostic value. In fact, with ESR, you're probably better off flipping a coin rather than doing the test, and then CRP is not that much better. And then when you look at synovial fluid, synovial cell count, synovial neutrophil percentage, taking an aspirate in the clinic, the diagnostic value is better, but it's still not that great. So when we look at preoperative diagnosis of shoulder PJI using serum and synovial lab work, it typically is not that helpful. And typically we're using preoperative patient and shoulder characteristics to help us guide whether we think we're going to get positive preoperative positive culture. So the male patient is definitely a huge risk factor. Young patients, testosterone use, recent cortisone injections, and radiographic humoral loosening are usually typical signs of potential infection or the risk that you're going to encounter positive cultures. And so in one study, we looked at this, and just using preoperative patient and shoulder characteristics, about 75% of the time, we were able to figure out whether or not we were going to encounter positive cultures. There are other interventions, like you can do aspirations. You can also do a pre-revision arthroscopic or open biopsy, but that does commit the patient to another general anesthetic. And so it really points to the need for a point of care test where at the time of the surgery, instead of sending cultures and waiting a week, that you can figure out whether there's presence of bacteria at the time of the surgery. In terms of treatment options, you can look at antibiotics alone, debridement, antibiotics, and implant retention. Most people have looked at single stage and 2-stage exchange as the primary ways to address shoulder PJI, but I would say more recently, people have become more interested in debridement, antibiotics, and implant retention, mainly because, for example, in this X-ray here, if you have a very well cemented humeral stem, removing that thing is going to be very morbid, and you're probably going to lose a lot of the bone and soft tissue that oftentimes gives a patient, comfort and also function in their shoulder. So if you look at 1 versus 2 stage for shoulder PJI, there's been multiple systematic reviews and meta-analyses, and every few years the data comes out, and it essentially says that single stage revision for shoulder PJI is as effective or more effective than 2-stage exchange. But really, you have to consider selection bias in these. The more virulent bacteria and the more virulent infections, and the ones with more obvious signs and symptoms are probably being treated with 2-stage, whereas the ones that are less virulent probably are getting 1-stage. So it's hard to interpret the data in the literature right now. We did a study looking at single-stage revision for failed shoulder arthroplasty with positive cultures for Propionibacterium and Bacterium, and really found that there was no difference in patient-reported outcomes or revisions. And then this was a recent article of a large number of revisions by Dr. Frankel, and he treated primarily most of his patients with a 1-stage procedure, and his recurrence rate in 1-stage procedures with definite or probable infection was only 6%, which was pretty good. So I think some of the major questions with treatment management, surgical management, is whether or not you need to take these well-fixed implants out, whether they need to be removed, and what the role of debridement, antibiotic, and implant retention is. And so when thinking about the approach to the patient, we're always thinking about the goals, which, usually our priority with infection operations is to eliminate and eradicate all bacteria. But in the shoulder, sometimes we always have to consider what the impact is, what the morbidity is, and what the impact on function is. And so when we look at all these options, my general approach is just to think about what the most effective infection operation is that you can still maintain a reverse arthroplasty that can be reliably implanted. If you try to take out a well-cemented humeral stem and you destroy all the soft tissue that keeps a reverse arthroplasty stable, or you lose all the bone stock that leads to humeral implant loosening later on, you may actually be doing a patient a disservice by trying to get rid of all the bacteria. So another question is that because we don't know the culture results until after surgery, what do you do about antibiotics while you're awaiting the culture results? And so Jay Yao, who was one of our previous residents, published a couple papers on the use of oral and intravenous antibiotics. And so we had this protocol called the red and yellow protocol, where if we had a high suspicion for infection, we would do the red protocol, which is a PICC line and antibiotics for 3 weeks. We'd get the cultures back, and if they were positive, we'd treat the patient with IV antibiotics for 6 weeks, then follow that with oral antibiotics. And if it was negative, we'd stop it. And then the yellow protocol was for low suspicion of infection, where we'd start off with oral antibiotics for 3 weeks. And then if it was positive, we would actually put the patient on a PICC line and IV antibiotics, followed by oral antibiotics. And if the cultures were negative, we would stop the antibiotics. And with this approach, we had about a 90% success rate with in terms of infection-free survival. But the big thing here is that the rate of antibiotic complications was pretty high. Is definitely higher in IV versus oral, and some of these complications that you can get with a PICC line are pretty significant, with DVTs and some heart complications. And then there's more recent literature that came out. This is an Oviva trial where they compared oral versus intravenous antibiotics in a randomized controlled trial. This is for bone and joint infections. There was a subset that was prosthetic joint infections, but what they found is that there was no difference in IV versus PO. There was another study that also looked at extended oral antibiotics. And these were all prosthetic joint infections. And they found that persistent infection was actually lower in patients that got prolonged antibiotics, meaning they got 6 weeks of antibiotics followed by an additional 6 weeks of oral antibiotics. And those that had the additional antibiotics had a lower rate of persistent infection. So in taking all that information into account with the red and yellow protocol, we've sort of transitioned a little bit more towards a different protocol, which is mostly just oral antibiotics. So if there's not an obvious infection, we're doing oral antibiotics for 3 weeks while we wait for the culture results. And if it's positive, doing an extended oral antibiotic course, whereas if it's negative, then we discontinue the antibiotics. But the data on shoulder using this in shoulder PJI is still pending. So one of the hard things about defining success in PJI treatment is that you never really know if you've eradicated the infection. The only way to really know is to open the shoulder back up and sample the tissue, but we're not going to do revision surgery on everyone. So how you define success in shoulder PJI is really difficult. Oftentimes, you can define it as a reoperation with positive cultures, and that's a failure. But really, we're looking at absence of reoperation. We're looking at the patient's functional outcome, whether they got pain relief, and whether they were satisfied with the outcome. So overall, defining success in PJI is shoulder PJI is nebulous and very challenging. So in summary, in the last 10 years, what we've learned about prevention is that C. acnes lives in the sebaceous glands. We don't know how to eradicate it yet. We don't know how to prevent inoculation to the deep tissue. With diagnosis, we've learned that serum and synovial testing has limited utility, and that we need to really determine how to detect bacteria at the time of the surgery. In terms of treatment, I think the trend here is that single stage exchange is likely sufficient, but we need to figure out when debridement antibiotics or two-stage is more appropriate, and when post-op antibiotics are needed, and whether IV or oral is sufficient. So what we don't know here kind of guides our next steps, which is to find prophylactic measures to keep the surgical field sterile from C. acnes, create an intraoperative point of care test to determine whether bacteria are present, and then through multi-center databases, we can use larger sample sizes to determine what our treatment success is. Thank you.
Thank you, Dr. Shu and Dr. Yamaguchi, for that wonderful talk. And of course, it's clear to all of us that you and Dr. Mattson and some of your trainees actually own this topic and are the experts in it. We have quite a bit of time for questions, and feel free to speak up. You can also raise your virtual hand and I'll see that and call on you, and you're also welcome to text me. Well, I can start off, and I'm certain that you have all thought of this, and so I'm wondering why, in terms of testing in the OR, would it be possible to use some kind of ELISA test? I don't know if C. acnes has any distinct proteins that could be specific and sensitively detected by a test like that, but has that been looked at?
So that's a great question. I think that's kind of the holy grail, to know exactly what you're dealing with at the time of the surgery to guide your surgical treatment. And so right now we don't, but based on all this genetic analysis that we're doing, we're currently looking into something called aptamers, which look at specific sequences, and it's just like a COVID test where you take tissue and then you can run it through and then potentially identify whether a virulent strain of Cutibacterium is present. So that is something that is being looked into, but still being studied now.
This is Rick Mattson here. You can see why Jason is viewed as the world leader in this research, and you can also see how effective he's been in involving students and residents and fellows and people from other specialties, and really created a multidisciplinary task force, as well as his multi-institutional studies, which point to the fact that large data are going to be necessary to answer some of these big questions. One of the questions I'd like to have John and Jason comment on is, if we assume that every male has loads of Cutibacterium in their sebaceous glands, and assume that Dr. Yamaguchi is incapable of making an incision for a shoulder arthroplasty without cutting through a bunch of these glands, why doesn't every male arthroplasty get infected, since they apparently are all inoculated?
That's a great question, Dr. Mattson. I think part of this relies on the different strains of Cutibacterium as well. I didn't present on this, but there are different strains of the Cutibacterium, some that have more virulent factors than others, and some that rely on the skin, kind of like what Dr. Shu showed, that there were the more of the deep inoculated tissues had more of the biofilm producing and hemolytic effects. And then there's also different between all males, there's a range of testosterone between everybody. So those are my initial thoughts.
Yeah, I think that's exactly right. So on any person's skin surface, they have different strains of Cutibacterium on the skin. And so some people have more virulent strains, some have that are considered more commensal or pathologic or pathogenic. And so there are some strains that can just adapt to the deeper environment better. And then you have to take into account what the host response to that bacteria is going to be. So, that's why we probably don't see everyone getting infected. But I also think that there are plenty of patients that have surgery that might have vague pain that probably have some kind of, low-grade infection that we can't diagnose. So I think that's probably a little bit more prevalent than we realize.
I don't see any hands, so I'll ask you another question. I know it's complex because with age, immune function declines. But I'm wondering, testosterone levels also decline with age, and have you noticed or have you found that there's a potentially decreasing rate of infection with age due to decline in testosterone levels, or do other factors mitigate against that potentially beneficial change?
Yeah, that's a great question, Dr. Chansky. I think one of the, again, studies I unfortunately didn't have a chance to show, but one of the risk factors is younger age or less, that was categorized as less than 50.
Interesting. I see Dr. Davies has his hand up. Jonah?
Yeah, Jason, John, those are excellent talks. Jason, I was wondering, you presented really nicely on the culture positive, the description, the quantitative, and like the time to positivity. Is there any thought to having some sort of scoring system where you could just incorporate all of that and say like probability of infection being X? You know what I mean? Like, so time to positivity, you put the day in, amount, 1 + 2 + 0 + whatever, and then just kind of spitting out a probability of infection. And then could we incorporate like other things like your pre-operative risks stratification that you put in and those other things?
Yeah, I think that's a great point. I think it's challenging because it's hard for labs to sometimes report time to positivity. And so I think if you're able to get time to positivity and use semi-quantitative culturing, and then you put this all into a large multi-center database, sort of what we're trying to do now, I think there is a possibility that we can better know whether you're dealing with a virulent strain of bacteria just by using those characteristics. And then you're right, if you put all these, variables in, like the preoperative characteristics and then the culture characteristics, you very likely could come up with some type of algorithm that could just spit out what your chances of having a real PJI is. So that's a good point.
That would be a good, that could be a good, student or resident project to kind of look at that too. It'd be fun.
Oh, sorry.
It's a great idea.
Hey.
As you know, the Musculoskeletal Infection Society tried to do that, but under the leadership of Dr. Parvizi. But the problem there is they didn't distinguish infections from organisms like Cutibacterium from those from Staph aureus. And so the results were sort of confounded. And I think what John and Jason has pointed out is that, particularly with their comments on pre-surgical lab tests, to show that many of the things that were part of the Musculoskeletal Infection Society study just don't relate to the kind of infections that we're talking about. But I think Jonah has put his finger, as he usually does, on an important opportunity. And this would be a great sort of artificial intelligence kind of project, looking at all the data that you could collect on these people and seeing if you could come up with a predictor. That would be a very exciting project.
Dr. Yindao is asking whether blood levels of testosterone preoperatively are correlated to infection risk, and then also has the amount of hair growth in the area of surgery been correlated to infection risk. And I'll lump that in with Dr. Bowie, who is asking, does topical or oral retinol use have any impact on P. acnes or rates of PJI? So testosterone, hair growth, and retinol.
So the first question about blood level serum testosterone. So I mentioned that study that Dr. Schiffman had done looking at testosterone and Cutibacterium in the skin. As a follow-up to that, we are prospectively following patients that have serum testosterone. We're getting all their serum testosterone levels and looking at infection rates. But as you can imagine, that's going to take hundreds of patients. And so we're a couple hundred patients into that, but you really need a few hundred. So hopefully we can answer that question soon. Hair growth correlation with risk of infection. There have been some small studies looking at that, but I don't think there's a strong correlation there. I think testosterone again is the serum testosterone levels are really what the driver is. And then in terms of retinol use, that definitely is something that had come up a few years ago as, you know, potentially something similar to benzoyl peroxide or hydrogen peroxide that you can add. There is some side effect to using retinol and also benzoyl peroxide. There can be skin irritation, and at least our group decided not to study that just because of the risk of irritating the skin prior to surgery. So it is a good point. That is, you know, an acne treatment, but it has not been studied yet in the shoulder.
One more comment I'd make. I don't see any other questions. It's really interesting that you've been able to work with the infectious disease doctors and treat more and more of these patients with long-term antibiotics as opposed to surgery, recognizing that sometimes it's with revision surgery, it's really unavoidable to end up with significant bone loss and make your subsequent reconstruction and functional outcome really challenging. And I think that's underutilized in total hip and total knee patients. And we often are engaged with somewhat of a philosophical battle with our infectious disease doctors and their willingness to, you know, give patients a trial of long-term suppression. And I'll often note that they're willing to use long-term chronic antibiotics for other conditions, whether it's chronic UTIs or even acne in kids. But they seem to become incredibly resistant to that modality when we're talking about salvaging a joint that would otherwise require a really extensive, potentially destructive procedure. One more question. Dr. Roberts is asking if there's any idea on how the testosterone effect is mediated, and anything about host immune response or environment that could mediate how different patients respond differently to the same infectious burden.
Sorry, that was just we asked the question of, like, you know, there's bacteria present. Why are some people getting infected and some people not? Just thinking about it from a cancer angle, right? We all have cells that are turning over and doing their own thing. Some of us are able to fight it off and some of us are not. I think you guys talked a lot about how testosterone maybe plays a role. And so I was just thinking about, you know, what's different about each patient is something about their immune environment. And so I was wondering if that's something you guys would look at.
Yeah, Jesse, you bring up a good point. I think the host response is a very critical portion. We probably have not studied that as well. Yeah, I think that's just in general a more difficult thing to study. I mean, we can study patient demographics, but when it comes to like immune modulation and how you respond to bacteria, I think that gets pretty complex. We have not yet kind of dug deep into that yet.
And then Alan
There's
Green,
a lot of immune microenvironment researchers at Fred Hutch who might be interested.
That's a good point. You should probably talk with them.
And then Dr. Greenwald is asking about the timing of infection risk. The infections primarily related to early phase post-surgical contamination, or are they also seen in the later phases?
It's interesting because these are low virulence bacteria, a lot of times we actually do not see these infections until years after surgery. So there are a number of patients with Cutibacterium infections that show up years after surgery. And so I think they may just lie dormant and something changes, whether it's the host immune response or their ability to fight off infection, or something just triggers, whether it's implant loosening that might trigger the environment for bacteria to replicate. I think you know, most of these are actually seen more in the late phase than early.
Okay, I think that will do it. Well, thank you, Dr. Yamaguchi and Dr. Shu. That was a fantastic grand rounds, and congratulations again on developing essentially a new field within shoulder surgery, and I think there are going to be more great things to come out of your research program. Okay, I hope everybody has a great day and a great week. Thank you again. And don't forget to text for your CME credits. There is a strict time limit for getting that done. Thank you.
Thank you. And Dr. Chansky, I'm just gonna, in the last few minutes, I'm gonna share this this screen just to thank my co-residents and also congratulate those that have matched, and looking forward to where Elbu is going to hand in a couple weeks.
Thanks, John. Great photo. You'll need to get that framed and hang that up in one of our offices.
Absolutely, will do.
All
Thank you,
right.
everyone.
See you. Thank you.